Thank you, everyone, for coming to this session today. We're happy to have this panel to talk about what's next in provider-to-provider care delivery. I have with me, I'm Michelle Hager, I'm the managing partner of Blue Cirrus Consulting, and I have with me Dr. Stephen Morgan from Carilion Clinic, the Chief Medical Information Officer. I also have Dr. Matthew Faiman, who is the Virtual Health Medical Director for NextCare, and we have Deanna Larson, who is actually a Blue Cirrus Senior Advisor. So we're happy to have all of you here today. Thank you for being here. So my first question is around this idea of artificial intelligence and machine learning. We hear a lot about that and how that's going to modify and innovate healthcare in general. So tell me a little bit about where you think that's going to go, your thoughts around how that's going to assist providers in the care that they give, and also how that might be able to facilitate between providers. And Dr. Morgan, I'll let you start.
Certainly. Thanks, Michelle, and thanks for the opportunity to be here. I think that artificial intelligence or augmented intelligence will be the way. I think we can agree to that. We are seeing more efficiencies with our providers being able to provide decision support, being able to automate guideline therapy by being able to do some predictive or in some cases prescriptive analysis to be able to drive care innovation. We also are seeing that not only with our clinicians, but we're seeing that also with our providers, but also our nursing staff and our clinical staff to be able to help them do their jobs more efficiently, and in some cases, operational staff, being able to guide them on what may be next in a patient's care journey.
And a slightly different bend to that, taking the same question though, Deanna, around AI and machine learning, we hear that, sometimes this idea of artificial intelligence and machine learning might actually be so advanced that it is, in fact, making decisions about clinical care. And have you thought about, I've heard some discussions around the legal implications of that. Should the AI, in fact, be quote unquote licensed like a physician because there's some decision making around that? What are your thoughts?
Sure. Thanks so much for that question, Michelle. What I think about that is I do think the data that you get out of everyone kind of constructing their data together, so we can learn from the what's actually happening, so we can put the appropriate algorithms together to actually feed that machine, to feed the outcomes. My thought is licensing it, putting it together in a way that really is beneficial to the larger group of individuals to improve outcomes. I really think maybe you pay to play, Michelle. So if you license your product and we can put all of our data together to understand what's really happening and put the appropriate algorithms together that physicians, nurses, other clinicians are comfortable with, maybe that would really be the best advantage efficiency-wise, reduce redundancy, et cetera. So I'm a fan of licensing for the perspective of we could really comb data together, and maybe we need to pay both the payer, could maybe pay the physician group or the clinical group, as well as the patient to actually contribute their data to help us learn quicker with bigger groups of data numbers.
Those are great points. Those are great points. Dr. Faiman, when we think about this idea of burnout and capacity challenges that physicians and clinicians have, and we hear about this every day, whether it's because of a great resignation per se, or because there's just already a lot of care that needs to be provided with not as many clinicians coming out of graduating along the way. What kind of workforce innovations have you been seeing that would help and emerge with this idea of capacity expansion and reducing burnout?
Yeah, Michelle, it's a great question. And so as we have seen where 2020 was the year of COVID and we had to manage around those challenges this past year and 2021 as well, 2022 has been sort of this year of dealing with this great resignation and the labor that goes along with it, and thinking about leveraging technologies and digital tools and things like AI even, and how to build the proper integration into the workforce without putting more strain already on a strained labor force. And I think doing this thoughtfully, if you actually create, the proper workflows and integrate them in your day-to-day and actually bake them in, like these are the things that, I think about it from our clinicians. These are the things we get asked about all the time. And specifically, like making sure that these are in the onboarding tools and how you build them out day-to-day, because this way, if you set them up that way, then what happens is it actually improves the efficiency with how you're delivering care, as opposed to adding another piece of like, how do I deal with tech checks and how do I deal with this? It's just going to be onerous, and it adds to the burnout, and it makes it actually a more appreciative way of doing things.
Such a good point. I'm curious, Dr. Morgan, what is Carilion Clinic doing to assist with burnout and increase capacity with the amount of folks that you have to care for in the state of Virginia and some in North Carolina as well? Your coverage area is very large. It also includes a lot of rural patients as well. What types of innovations are you doing to assist with burnout and increasing capacity, and also increasing the ability for providers to work together?
Again, another great question. And I wish we had all of the answers, but I will share with you some of the things that we are doing. Really, probably the biggest focus right now is data, and being able to have the data to better understand where those efficiencies live. So being able to look within a electronic medical record workflow, where do we have opportunities to either change a workflow or to train to get more efficiency from our providers, and being able to use that data to then drive meaningful change. In other clinical areas, we're using artificial intelligence or predictive models to be able to get our staff to work to license. So being able to provide alerts in the right point in the workflow. I think Matt's spot on. Workflow is what we need to focus on so we don't add burden, but in the right spot of the workflow that you can have the outcomes that you're anticipating for that AI solution or that predictive solution. Another area that we're focused on with over 13,000 employees is how can we make it easier to do collaborative meetings, those type things. And clinicians are part of that. How can we make it easier and use some of the tools that we have in digital to be able to do more collaborative meetings, improve some of the education that we're doing. We've all learned how to do education online a lot more efficiently than we had before. So those are some of the things that we are looking to decrease the burnout, which is also contributing to such a huge employee turnover that we're seeing, particularly on our clinical nursing staff, and looking for different ways to make things easier and more efficient for them.
It's a great point. I think that obviously will help you with connecting to your rural folks as well, make them feel more connected to sort of mothership in Roanoke. Deanna, when we think about things like, I hear in the ether this idea of virtual first, and when I think about that, we know that like standard of care it's a standard of care to provide telestroke services, for example, and certainly tele-ICU services. Any other things that you think about that are standards of care on the inpatient side that we're going to see as kind of the next big thing for this provider to provider or even provider to patient modalities or models of care?
Sure. Well, I think about when I think about the inpatient sector, I think about those places where there's a lot of specialists who are getting together to provide the care service. So how do we reduce kind of the redundancy of the visit at the bedside? How do we support, I think about, nephrology patients or neurology patients. Once they're hospitalized, they still have a multitude of specialists coming to the bedside. So how do we get those, I think I heard it said earlier by Dr. Morgan, how do we get those care groups together virtually? How do we make sure that the call that's coming for the patient need at that point is communicated easily across those multiple specialists so that they can agree on the next step of care that's provided? And, Michelle, I really think too, it really goes to the home setting too. So I'll think about a very acute kind of patient that's in the home setting, and I'll just use renal dialysis as an example. Those patients do very well quite a bit of the time, but there's an acute situation that arises. It could be just a dietary thing, or it could be a medication piece. How do we quicker know through AI or protocolization that the patient can understand so the right level of NextCare is sought? Oftentimes they'll try to go to a specialist, but maybe there's a better entry of care virtually, so that first level person can help really understand what that patient needs to do next. Do they need to see the neurologist? Do they need to see the nephrologist? Or do they need to see their family practice provider? And I often think there's a little runaround there because we're trying to identify who's the right physician or clinical team to next take care of that patient. So I think those algorithms or those protocolizations through machine learning can really help us do that and make a good virtual intervention.
Yeah, could I add, and I'll add, it's a great way to look at sort of the patient journey, but it's managed by that sort of provider team. And I think about it as we've moved more and more to value-based models. Working at Cleveland Clinic, I had a mature internal medicine practice for so long, but it was thinking about how to reduce, the readmission for like complex medical problems like CHF and others, and having the data that Dr. Morgan has mentioned, like having that be able to be analyzed so that when we get alerts into the team, the care team, that we decide that yes, virtual first is appropriate for that virtual triage. And then we can communicate even through the patient portal, but then we as a team can huddle provider to provider, like, is this primary care to cardiology that this patient needs assessment, or is it primary care to, other specialty nephrology because the patient is, near dialysis, to figure out how to leverage the ambulatory assessment so that then you can work among the team. And ironically, sometimes it's as simple as, picking up your phone and calling that provider, but you've actually done a whole lot of analysis, through the EMR provider to provider. So that's sort of leveraging some of those tools.
Right. And calling those providers, because you can get billable services for that too. But go ahead, Deanna.
So what's interesting about that was the payment over the payer. The earlier, so to that point that was made, we may end up as a patient going to the wrong specialist and and it might take us a week to get there. And then they're saying, oh, no, you actually need to see the urologist. This is, more of a mechanical issue. You need to go there. So now you spend another week or two getting into a urologist. So you can spend weeks getting to that right level of care, where if we would have went maybe as a patient to an internal medicine team, likely they would have directed us, if they couldn't have taken care of it themselves, which sometimes they very much can. But if they didn't, they would have directed us likely to that right first stop. And so from a payment, yeah, if you're free to go wherever you want, you may choose that wrong specialist and your care is going to be delayed more. So I'm very much a proponent, even with the payers. How do they help, again, really incentivize that kind of care model? And much of that can be done through virtual access.
Michelle, one of the things that we have been fortunate enough to get some reimbursement for through our academic department is the concept of e-consults. To be able to have a primary care still practice. So if I have a patient that I'm not sure about, rather than trying to get them into, unfortunately, what's turned into a large referral work queue just because of backlogs that I'm sure we're all familiar with, being able to get that right message, just like Deanna said, hey, what do you think? Should I, is my next step to, send them to pulmonary, or do they need to see cardiothoracic surgery for a pulmonary nodule? Those type things. But having that reimbursement made the difference, being able to have at least some reimbursement. And we're trying to work on a similar concept and try to get the reimbursement for curbside consults in the hospital. Being able to, if I'm at one of our regional hospitals, that I can reach out to a specialist at our flagship hospital and be able to have some reimbursement as we have that conversation to help guide that patient's care.
I think that's so important. It's a great point to bring to the discussion. And I also think it's about an integrated care model. That's really what I take away from your everyone's points here about this. And what I see in the academic world as well is nursing schools, medical schools, putting emphasis on this idea of integrated care models, which I think is so important for the future of medicine. And I think you're right, payers need to keep up with that as well. This is how we're going to practice medicine in the future. We need every part of the care team. And myself with a pharmacy background, I always want to tout the pharmacists as well. Don't forget them, they're important. When we think about this idea of virtual collaboration, we're utilizing new tools to provide providers to be able to collaborate together. For nurses to collaborate together, both as peer-to-peer education and also just the general clinical collaboration in general, and the technology is enabling that. What do you think the sort of, again, next big thing in that clinical collaboration space will be? Are we talking about, technology messaging? Are we thinking about more video collaboration, patients and families together? What is it that we kind of see out there? And Dr. Faiman, I'll let you start off, and then I'll go to you, Dr. Morgan. And you're on mute. Sorry, Dr. Faiman.
Thank you. Sorry about that. See, we always have to keep our checks honest.
Right.
Guilty as anyone else. The thing about that piece is so critical, and I guess for me it's about efficiencies of care and how best to do that. And I think about like the Project Echo that was in the past, or for those who remember it, it was really about provider to provider education, and it was done where the hub site was helping the spoke sites that may be at a disadvantage just because of where they were relative for the amount of patients they were caring for and the specialty access. Nowadays, we really have shortened that distance in so many ways. And I think about education of, in real time that is sort of necessary. And the e-consult for me is like crucial. I've used it in so many of my patients, but I also think about the real-time assessment of the patient sitting in your room, and you want to get real-time clinician to clinician assessment for whether it be telestroke, tele-ICU, or just that clinical assessment where the patient is there. And so starting with it in a simple way so that we can get internal adoption will allow these things to grow in a lot bigger ways, moving into the future. So when you can sort of, reach out the bat sign and get a hold of whatever provider of the day is for that service and get an answer, that education then makes the primary care much more willing to take on a lot more complexity of care at the front end, which then makes the whole health system much more effective and efficient.
Good point, Dr. Morgan.
I totally agree with Matt's comments. Taking it to technology, in addition to e-consults, video collaboration, we're starting to see more of that and use more of that to where we'll bring multiple clinicians together, including pharmacists. So pharmacy is part of a large part of our diabetic practice to be able to bring them on board. And I think another, critical point we've touched on is making sure the patient's there. So it's not only, being able to have now with most platforms, having video collaboration between everyone and the patient is at the center, right? And being able to interact with these different specialists. And it's something that we're working toward. We've done that in pockets. I was referencing with diabetes, but it is, I think our physicians are starting to feel comfortable enough with virtual and with video that they see the value, and they see the value of these interactions, and they're starting to see the time savings if you do this appropriately and you have the right technologies that are not adding additional clicks or changes in the workflow.
Yeah, so important. Deanna, I'm going to have you respond to that as well. But because of your nursing background as well, I'd love to hear your perspective on this idea of virtual collaboration related even to virtual nursing that we're seeing now.
Well, I think a couple different ways I think about that. So first of all, for virtual nursing, we all know workforce is the crunch today. It's what we've got to deal with. So virtualizing the knowledge of nursing, making that something that we can actually utilize in patient interaction, that we can pass off one nurse to the other, and more importantly, one clinician to the other. You know, you mentioned the pharmacy team, the therapy team, the medical team, and the patient. It's all been said, but how do we make that accessible? And I think their technologies are coming along. I heard it said the clinical team, especially medicine, is getting more comfortable. I think we all have to be more comfortable that everybody's in the room and people are able to speak what's on their mind. Nurses know a lot about patients that needs to come forward to the rest of the team. They spend the most minutes, if you will, in the patient room, if it's no matter if it's a clinic visit or if it's, you know, an inpatient visit. So making sure that that's comfortable for to maximize the workforce. Again, it comes down to payment often. So how do we make sure that that clinical team is reimbursed? We do have the right specialists available for handoff and reimbursed and paid appropriately. And I think it was well said that the clinical teams are learning that it is more efficient. It does utilize their time better, but that's a long learning curve. And it does a bit get in the way of us being as effective and efficient as we can when the reimbursement models don't line up. So I hate to just hit that page too hard, but you know, I'm really excited about some opportunities for some demonstration models because I think patients and the medical team, that all clinicians will come out ahead. We all want to do our best, but it's hard to be efficient right now in the broken up technologies that are available to us.
You're absolutely right. And then the last couple minutes that we have, I'll ask you each to tell me what's the exciting thing that you're seeing in healthcare, and I'll share my own. I'm excited to see what's going to happen with you know, sensors and biosensors for, you know, patients and what we use in athletes now to see what people are doing. And I think that will translate into everyday folks and how we might be able to better manage patients that way. Deanna, what is your thing that you're excited and you're seeing?
I'm really excited, especially in rural cares, about the obstetrics care, both the trimester care, so mothers can have more knowledge and accessibility during the second and third trimester and specifically, and also rural delivery, how those clinicians can have some access to obstetricians, earlier identification of high-risk deliveries, and really making sure those moms and babies come out okay. Pretty excited about that.
Great point. Dr. Faiman?
So tagging on to what you're saying, I'm super excited. We can't get away from, you know, patients themselves read a lot, whether we like it or not. Dr. Google is, you know, ubiquitous at this point. But, you know, marrying like wearables, as you referenced, precision medicine, and the whole idea of population health, I think they all can come together in a way that we can be smart about what we do with it. And we can, you know, take the genetic makeup of individuals and wearables information and analyze it using AI smartly, and actually deliver the things that are part of those social determinants of health that really make up much of what gives patients as much grief as the diagnosis itself. You know, the sleep, the fitness, the health, the eating, the access to care, the demographics, the financial. And so I feel that the piecing of all those together will be able to actually be much better able to deliver care thoughtfully, smartly, and really in the patient's home as their care journey goes along.
Love it. Dr. Morgan.
So there are so many new ideas that are out there that we've touched on, and trying to come down with one, Michelle, is very difficult. But one that's just top of mind is really ambient digital voice technology. To me, I think from an efficiency standpoint, being able to have those capabilities as we're seeing patients, whether that's in an inpatient or ambulatory, and having the AI available that can essentially scribe that that conversation and be able to then populate in an electronic medical record is one of the things that I am very excited about. Lots of opportunities there. We still, back to the clinician burnout, that is still, if I look, documentation burden, not only for, but clinician is significant. And if we could reduce that and be able to do that in an efficient way and allow machine learning and AI, to me, that's something that is very exciting for the future.
Dr. Morgan, it's impressive that you came up with another great idea after 3 great ideas to come through. So that was fantastic. Thank you so much. Thank you to everyone on the panel. Thank you for those of you who are listening to this presentation. Dr. Morgan from Carilion Clinic, Dr. Faiman from NextCare, and Deanna Larson, who's a senior consultant with Blue Cirrus, advisor with Blue Cirrus Consulting. I was honored to be on this and moderate this panel today. Tom and the High Acuity folks, thanks for inviting us to do this. I hope that we gave everyone just a little bit of information to take back, a little nugget to take back to your own workspaces, and certainly reach out to all of us if you have any further questions and want to talk about these topics in the future.